So we're going to look at the knee here, and we're going to see how to inject it, and you can be injecting prolotherapy, PRP, stem cells, whatever. Prolotherapy is sort of the basis of all regenerative techniques, so let's assume we're doing prolotherapy, but PRP could be used as well. We're going to inject certain structures routinely. If we're having, for instance, an arthritic knee, we're going to inject intra-articularly. We're going to inject the collaterals on both sides. We're going to inject the joint lines called the coronary ligaments, which hold the meniscus in place. And we're going to inject the pes anserina, which is always a sore spot with arthritic knees. And that's sort of my standard for if somebody comes in with a degenerating knee, which you're going to see a lot of. Now, if somebody comes in with a specific problem, we're going to, through our examination and history, identify that problem, and let's say it's a patellar problem and they have a patellar tendinitis. Well, then I'm not going to do all those other structures. I'm just going to do the patellar tendons and maybe the quadriceps tendon if that's a problem, if it's a tracking issue, so it depends on the patient. Young athlete is going to be treated differently from a 50-year-old with beginning knee arthritis. So let's just assume we're going to treat everything so I can show you stuff, all right? So the first things we're going to show you is how to treat collaterals. So the medial collateral over on this side, you can feel the medial collateral on most people, all right? And the way to feel a ligament is to roll your fingers over it, and you can feel it, and you want to feel it until it sort of peters out or gets thinner, and you want an injection spot on the tibia and also on the femur up here, okay? This is right around the adductor tubercle is when it sort of is a good place to inject it. We'll inject it with a 25 gauge, 1.5 inches, and we'll just pepper using about 0.5 cc in each spot. And by the way, after palpating it, I would draw a little circle where the emphasis is. We're not going to inject it in its mid-zone. We're going to inject it only at its attachment sites. And that's important because all ligaments we inject at their attachments, not in their mid-zones. We don't want to weaken them. We want to strengthen them. And the way to strengthen them is do the emphasis, okay? That's where the weakness occurs. So that's medial collateral. Lateral collateral, we start by finding the fibular head and marking it, and we then follow the ligament up above I'm on the joint line now, and here I can feel it attaching on the femur, okay? So we're going to just mark that also, and to inject it again, we're just going to put the needle in and spread some stuff around. The fibular head, the ligament falls right here and attaches to the top of the fibular head, so we want to make sure it's okay to stick your needle in and sort of touch base on bone, but then you want to skin slide like this and hit the top of that fibula, okay? Now you want to be careful not to slide behind the fibula because you have the peroneal nerve coming out like this underneath the fibula, and if you were to go underneath the fibula, you can skewer it, so you don't want to do that. So that's your collateral ligaments. Now the knee joint itself, pretty easy to inject. The technique I like best is one where we come up at the posterior lateral corner, and using that technique I think minimizes your risk to the cartilage on the back of the kneecap and also the femoral condyle. And the way we do that is we draw a line at the top of the patella. We push the patella over, find the space that it's going to create, and draw us a line. And then in this posterior lateral corner, we'll find a soft spot. Just push your needle in there straight, not this way, not up, not down, just straight across, and it pops right into the joint capsule. And, if you were injecting, you'd feel a loss of resistance, and you inject there. And it's not the only way, obviously, you can inject a knee. You can pick the midpoint here. This is the standard approach, is to pick the midpoint, but again, you're still using one hand and picking up the edge there and pushing it in. This is a lot more problematic, finding your way with the needle, and you will definitely usually touch bone. Actually, you're touching cartilage and you're sort of writing your name in it, so I don't like this one quite as much. Other ways of injecting the knee are through the portals in front. So in front, there's two portals, one on each side of the patellar tendon. Draw the patellar tendon in, draw the bottom of the kneecap, the patella, draw the joint line, and here's one portal and here's a different portal, one on the medial, one on the lateral side. You can use either one, and the approach is to use a 2-inch needle, because studies show that when a 1.5-inch needle was used, it was only successful in entering the joint about 70% of the time. So and when it didn't enter the joint, it was usually in Hoffa's fat pad. So you want to use a 2-inch, and you want to come in, and you're probably about 20 degrees toward the midline, and you're probably 10 degrees above the horizontal, and you drop the needle most of its distance in, and you should have a nice flow, okay? Don't inject if you don't have a nice flow, because where could you be in? You could be in ACL, you could be in the fat pad, you could be in tissues that don't want your solution, okay? So you can go in either side like that, okay? So that's intra-articular, a few ways to get inside the knee without guidance. So the next thing I want to show you is the coronary ligaments. Coronary ligaments are very important. They hold the meniscus in place. So if this is the meniscus, the coronary ligaments are wrapping down on the meniscus and attached to the top of the tibia, okay? So you can't get them by coming in straight on the tibia. You have to get them by coming in on an angle, and I start usually a quarter, like a centimeter above the top of the tibial plateau, which I've drawn. You come in at about a 30-degree angle, and you catch the edge, and that's the coronary ligament. And then you angle medially and get some, and order laterally, and you do that in 3 different positions. So here, here, and here, and the same thing on the medial side. Similarly, start again a quarter, 1 centimeter above the tibial plateau at about 30 degrees, and try and satisfy yourself you're on the edge by slipping off the edge and seeing where the actual edge is, okay? Because what happens if you're too steep, where are you? You're in the meniscus and injuring it, which is not our goal. Our goal is to try and strengthen the meniscus, okay? So that's collaterals, intra-articular, coronaries. That's great. Now, what if somebody comes in and they have kneecap or patellofemoral issues? There's a few different patellofemoral issues we can have. One is a quadriceps tendinopathy, and for that we would try and stabilize the kneecap here, come in above the quadriceps, above the patella, and again try and find the edge and address the edge. And you know, you'll be palpating to see where they're tender. It's not going to be the whole thing usually. It's going to be either this corner or that corner, and that's where you'll focus the injections, okay? Similarly, for a patellar tendinopathy, you come in below the patella and angle up, and again I use this hand to stabilize the patella and sort of push it from the top, and that tips it up just a little bit, and you find the edge and you walk along the edge. For the attachment site down here, it's more of a grid pattern, and this is very helpful, not just very helpful, but it's the treatment of choice for Osgood-Schlatter's disease, okay? Somebody comes in with Osgood-Schlatter's, that's the pattern. You just make a grid along that tibial tubercle. So there's a little bursa behind the patellar tendon here. If you feel like that's the problem, go down, touch bone, and then come back just a millimeter or two, and you'll be in the bursa, and you'll hit the bursa. If you have patellar tracking problems, the patellofemoral ligaments can be addressed. For instance, if you have lateral tracking and it's pulling that way, we can address the medial patellofemoral ligament just by addressing all along here, the retinaculum, and down along the femur where it's attaching to the capsule, okay? That's about all the major issues. Let me show you the ACL. The ACL can be addressed, believe it or not, with palpation skills. The distal portion of the ACL attaches to the tibia between the tibial spines, just in front of the tibial spines. So you sort of have to, in your head, understand where that anatomy is and triangulate and go for it and try and feel for that rubbery texture of a ligament. And that's the proximal piece. That's the distal piece. The proximal piece is on the inside portion of the lateral condyle. So where's the lateral condyle? Here it is right here. Okay, so the inside portion would be right there. Okay, so you have to sort of angle your needle up, and you need a 3-inch for this. And again, you're feeling for that consistency of a ligament, and you're feeling for bone. You want to try and hit the inside piece of that lateral femoral condyle. And that's about the depth that you're going to be. Try not to run out the back of the knee. It's bad form.